Welcome back to the Hot Flash Diaries. This is officially episode 2, followed by episode 3. We are actually dividing up this long episode into two because there is so much information, and I hope that you can all just enjoy and learn a little something from this wonderful human being who has agreed to come onto the Hot Flash Diaries podcast. I am so excited to introduce you to Dr. Maureen Slattery from Rochester, New York. She is a board-certified OBGYN with over 20 years of clinical experience. And she is also a certified menopause practitioner, certified sex educator, and a certified sexuality counselor. That is a mouthful.
It's a lot.
It's a lot.
It is.
So she understands, what it's like to be a woman and going through so many different things. But here's what makes her different. She's not just here to collect or has collected credentials. She is the kind of provider who doesn't just hand you a prescription and sort of sends you on your way. Instead, she actually sits down with you, listens to the whole story, and helps you understand what is really going on, not just with your hormones, but also with your life, your stress, and your relationships. Maureen has built her entire practice around breaking the stigma around sex through education and empowerment. She is not afraid of saying words like vagina and sex. I love it.
Not at all.
She treats women like intelligent humans who deserve real answers, not just quick fixes. She's having the conversations that most providers avoid, the messy, the complicated, the real stuff that affects how we feel in our bodies and in our relationships. And we couldn't be happier to have you here today to talk about libido and all things desire. Thank you so much for being here.
You're welcome. That was such an amazing introduction. I appreciate it. It makes me feel old too, because when I get to tell people that it's been I've been in practice for 20 years, it's a little insane.
I know. I was actually thinking back to how long I've been in this industry. And I was a nurse practitioner, or I've been a nurse practitioner for almost 15 years, then 8 years as an RN. And I think, how did that go by so quickly?
Yeah.
And so it really just, you blink and here we are. But I'm so grateful. And as I'm sure all of your patients are grateful, and all of your colleagues, that you do the work that you do. I had the pleasure of seeing you at the Pleasure Principle that Kristen Parisi put on in Hamilton last spring. And it was just a remarkable conversation. I really enjoyed it. So I thought for sure she needs to come on the podcast as soon as possible. So
Thanks
today
for
we're
having
chatting.
me.
Oh my gosh, thank you. Today we're going to really dive deeply into a topic that comes up with almost every single woman that I see in my practice, and that is that of libido and sex drive. It is a tough one because it's multifaceted, so many different things that are aspects that are part of why our libido starts to sort of tank or decrease as time goes on. And it's complicated because it's really so individualized. And I really want to chat with you a bit more about, your experience with libido specifically, as this is really your area of expertise. So one of the things I wanted to start off with is to chat about how what I find in my practice is women come in and say, hey, can you check my testosterone? Because I'm sure that that's what's causing my low libido and my low sex drive. To which I say, well, it's only a small bit of it, right? So let's talk about that.
I get that too quite frequently, and just all hormones in general, I think, as a menopause practitioner. But specifically with libido, I do a little bit of specialized kind of counseling, which is kind of awesome. I get a little bit longer with patients certain days. And then otherwise, I'm just seeing patients in a regular gynecology practice. And I feel like every other patient either has an issue with their libido, or they have an issue with their libido and they want me to check something. And it's such a can of worms, because in, a 15-minute office visit, if I go down that can of worms in a great amount of detail to kind of help them and educate them and show them how multifactorial it is, I get way behind for the rest of my schedule. Yeah. So a lot of times I'll give them a little bit of information that I've saved that I can kind of give as a handout, and have them schedule another appointment to talk about that specifically, especially if they came in for something else, like an annual visit or abnormal bleeding, because it's just so hard. And it actually takes longer, I think, to talk about than abnormal bleeding, really.
For sure.
Yeah.
It deserves its own visit. And luckily, when I do my consultations, I I actually reserve an hour for each patient, which I know in your case is not possible. But in that case, we're actually able to dive into it, not as deeply as I'd like to in some cases, because there are, in some cases, lots of other things happening. But you're right, it really does deserve its own conversation. And there's no way that you can get there 15 minutes coupled with other concerns. That's great that you bring them back.
Yeah, I have to. I mean, I have because I want people to know about this. It was actually the reason that I kind of came to doing this in my practice is because I was telling people stuff and I wasn't sure I was telling them the right thing because we don't really get educated about it in medical school, residency, and nurse practitioner school, PA school. It just doesn't happen to any near the degree it should. So there's a lot of misconceptions floating around. So I try very hard to like start the conversation and keep them engaged and then bring them back. But I also try to send them with something so that they have something they can do or look into or some context before we get a chance to talk again. I do get some like 1 hour time slots, but they're few and far between. And I do save them for my sexual health patients.
Amazing.
Yeah.
So in that, then you would agree that, if somebody came to you and said, hey, I just want my testosterone checked because I'm sure that that's the sole cause of my low libido. How do you respond to that?
Yeah, I mean, you might hear me say this multiple times over the 2 episodes, but sex is a biopsychosocial activity. So there is no way to just have it be biology without psychology or sociology or your relational component, right? Like unless it's solo sex, it's involving a partner or multiple partners. And so none of those things operate independently, and none of them are the only reason why you might be having a problem with your sexual health, right? The biology is a lot of it, but it's not even just hormones. I mean, there's neurotransmitters and all sorts of other, blood flow. There's all sorts of other things that are involved in the biological side. So I do get that a lot, but I try to kind of break that down as quickly as I can so that people are aware that everybody wants to be 22 again and have a carefree, like exciting sex life. And if I could do that, I would take us all out of menopause. It would take us all out of 20
Exactly.
years of sleeping with the same person, kind of like contextual stuff and make it fun again. But I can also teach them all the things that they can potentially do and all the things that are involved in trying to make it like good and fun and, worthwhile again.
Exciting again.
Yeah.
Yeah,
Yeah. Yeah.
absolutely. Yeah, because that is possible. I always try to really, get that message across that, you're not broken. There is so much hope here that things are going to get a lot better if you want them to get better. Because again, there's some people that are not very sexual and they've never been very sexual, and it doesn't bother them that they don't really care. And that's okay. I find in those particular patients, it's, oh, I was out for dinner with some girlfriends and all they really talked about was sex. And then I thought, well, maybe I should be having more sex. It's like, but no, that's just who you are, right? That's okay. But if you wanted things to change and you want to have a more, more desire and enjoy the actual act of intimacy and intercourse, then there are so many things that can be done. But it's not simply just checking your testosterone level, replacing testosterone, because inevitably it's going to be low. I mean, I have yet, unless the patient has PCOS
Yeah.
and they're either in perimenopause or very early menopause, I mean, the likelihood of seeing a testosterone that is anywhere close to normal is unlikely.
Yeah.
So, as I'm sure you would agree.
It's true. And when people ask me to just check their hormones in general because they're feeling perimenopausal, those are always normal too, with the exception of occasionally an FSH, right? So it's hard for me to even explain to people that we don't need those hormones, at least to manage what's going on. Everything but testosterone. Like we don't need it if we're managing those symptoms. So it's a hard kind of I feel like I tell the residents this when I teach them all the time. I spend so much time educating. If I had known when I went into, medicine that I was going to spend so much time teaching, but I literally every visit all day long, even at annuals, I feel like I'm teaching this stuff to people. Yeah.
It's true. Yeah. I
Yeah.
mean, even with non midlife topics,
Sure.
that's really such a big job, a big role of our, or a big part of our role is what I'm trying to say, is just educate, educate, educate. And I find those of us that really focus on that and do it well, our patients do better because they actually are empowered and have the tools that they need to be able to make changes if they want to make those changes. So
Yeah.
I'm so glad that you spend that time doing that. I feel like, overall, the idea of getting hormones checked is sort of because, as you know, there's a ton of sort of hormone influencers now
Mhm.
on social media. And so I find that while there's a lot of good messaging there that's empowering, a lot of it as well as misinformation. And I find that hard to deal with in practice sometimes, but it's also an opportunity to educate, right? So I do really love hormone replacement therapy when there's a need for it. Not
Mhm.
everybody is a candidate, but even things like progesterone, I find as a replacement in perimenopause for women who are not sleeping well, mood changes, terrible PMS. And when it comes to linking it back to libido, nobody's going to want to have sex if they're angry and they can't stand the sound of their partner breathing. I mean, yeah, I
Or
don't think you want to have sex
chewing.
with that or chewing.
That's
Oh
a
my
big one
gosh.
for me.
Right? And you're not sleeping, so any little thing just drives you crazy when
Yes.
normally you would have been able to function just fine, right? Because you were rested and you weren't deprived of progesterone.
Right.
Um, there's a role for sure, but I agree with you. Not everyone's a candidate, and it's just there's so much unneeded testing that's being done,
Yeah.
and then it's being used as like the tool to determine if you need treatment versus really the tool is the symptoms, right?
Yes, absolutely. Yeah, and improving quality of life.
Totally.
And sometimes that does involve testosterone, but not always. And honestly, no amount of testosterone is going to make your sex life better if you are chronically like you said, sleep deprived, or if you're the only one carrying the mental load running the household with all the schedules. And the older or the more complicated your schedules get, the harder it is to have like 5 seconds to yourself. Any kind of you don't have any space for it a lot of the time. Like our modern society has us like running like crazy. And if some of the day-to-day stuff is not shared very equally across partners or even with kids having some responsibility for their own stuff, like it's exhausting day in and day out. So no amount
It
of
is.
testosterone is going to help that.
Exactly. And so with that, tell us more about how stress and sort of that mental load really does physiologically affect desire. Because I think it's important for people to understand that.
Yeah, no, it totally does. I mean, first of all, not getting a good night's sleep increases your cortisol levels, which not only make it harder for you to like maintain or lose weight, but it does it decreases your capacity to deal with stuff that's kind of outside the mundane and the norm. Like you just don't have the mental wherewithal to kind of deal with stuff that comes along that you weren't anticipating or just getting everything done because you are fatigued with these higher levels of cortisol and stress hormones.
Absolutely. Yeah.
When you are stressed and there is nothing else to relieve that in your sexual relationship, it's almost like not being seen in some ways, but it's like if you're carrying all this stuff around and you barely have time to go to the bathroom or eat lunch or like you never get help with anything, it just drains you to have the free time and the focus and the energy to put it towards something that I don't want to say sex is frivolous, but it is not hunger, thirst, or sleep, right? As far as drives go, like it is not like a basic necessity. We all don't need to procreate and we don't all need to do it indefinitely through our entire lives between, puberty and menopause. So if we need to have space for that, like we need to almost create space. And if we are running around like a chicken with our head cut off, there is absolutely most of the time no space. If there's also no space for you, I would argue, because I find a lot of people have anhedonia. My friend Nan Wise talks about this all the time. But like, if you can't find joy in your life because you are just scheduled to the max and just doing the things that you need to do, but you don't have time for yourself, you've given up all the things in your life that might give you joy, even if that includes sex, like you don't paint anymore, or you don't read anymore, or you don't run anymore, then you don't really have the space to enjoy things in your sex life either. So it kind of goes back and
For
forth.
sure.
You got to make space
Yeah.
for these things.
It's so interesting that you say that because, again, personally, I have found over the last year, at least, if not the last 3 years, I have really done absolutely nothing for myself, really great at looking after everybody around me, but when it comes to looking after myself, I've really put myself on the back burner. And the whole premise of sort of season 2 of the Hot Flash Diaries for me is really about stopping that, putting myself first and really looking at, as a woman, what are the things that we need to do to feel better, looking at prevention, looking at really trying to feel better in my shell, in my body. And so then I can show up and be the best person that I can be. But you're right. When you start to pull away things that, or not do things that you enjoy, like I used to like doing pottery and all kinds of stuff, I stopped doing all of that. And then all you can think of is all of this crazy scheduling and things that you have to do and get this done and get the kids here and the other kid there and grocery shop and all this adulting that is exhausting. And we
It's
all have to do
exhausting.
it. I mean, but then what's worse yet is if you have a partner who doesn't help. Fortunately, John's great
Mhm.
and has been very helpful. But at the same time, there needs to be balance, and that is really tough. And so, of course, sex is not on the list of priorities when you're just feeling exhausted, you're feeling, overworked, and then you're not sleeping well. And so for me personally, progesterone has been a game changer because I've actually been able to sleep well and my mental load feels better. And some of my patients, I've been cycling progesterone a little higher doses in their luteal phase, so the week
Mhm.
before their period. And that has been a game changer for them as well. But I wanted to ask you specifically,
Mhm.
with women who are suffering with anxiety, depression, or other mental health concerns, how much how much more difficult or challenging is libido in women who already have perhaps some of this serotonin and norepinephrine, all of these neurochemicals that really affect our mood when we head into midlife?
Man, I mean, overwhelmingly, the women that come to see me, whether it's specifically for in midlife, if it's specifically for sex, or if it's for kind of like hormonal, considering menopausal therapy or both, I do find that almost all of them have like a change in their anxiety, their, their frustration tolerance, their overall mood. It's in the background and sometimes it's prominently bothering them, but then when I'll ask the question, it's there. So it is hard, especially in people who have been stabilized for a long time and then all of a sudden they're like, "Wait a minute, I've been on this antidepressant for 10 years." Like all of a sudden it doesn't work anymore. It's complicated because, I mean, as well, the antidepressants, like, it's almost like a flip of a coin if they're going to produce some form of sexual dysfunction, whether you're 20 or 70. So, there's already that in the background that people have learned to work around. But then now there's this, like, background piece that makes them almost think they're crazy, where all of a sudden they're like, come to think of it, like, I am way more anxious and I don't understand it. Or I feel like I have ADHD when I didn't before." And then you start asking them questions about how they did things, and you're like, well, maybe you did have ADHD, but like it was tolerable and controllable until, your hormone chaos has like unearthed the inability to deal with it, right? It's hard when people have this at baseline because I swear, I think right now I sometimes question myself, like, is the state of the world also making everything worse or not? And I'm 49 and a half. So I'm kind of in the middle of it with everybody else too. And I keep going like, actually, I know this, but also like what's going on in the world is like making everyone crazy. But then again, like it's not always affecting everyone the same way. I mean, I just feel like there's so many different influences, but the mood piece is hard because sometimes in order to control that or help that alleviate some of those symptoms and make things more of a steady state, you can sometimes even make, sexual desire worse. So it's a fine line. That's why everybody needs kind of an individualized focus and plan for what's going on. And they need to not just get
Absolutely.
a prescription, because if you don't take the time to find out that, like, yeah, the anxiety, it has flared up and I have a frozen shoulder, or yes, I don't have an interest in sex, but also like I can't get out of bed in the mornings. Like that plays a role both medically, physically, socially, interpersonally with our partner. And so if
For
you
sure.
don't address all of it, like you're not really going to fix it. So,
For sure. That's doing a mental health screen as part of any women's wellness assessment is so important. It's so important. And you're right. The thing is that, somebody comes in anxious or depressed, they may need an antidepressant or anti-anxiety medication, but maybe instead of increasing it, when they're in their late 40s, early 50s, perhaps it's because of the hormones that's why there's that sudden, spike or fluctuation, not so much that they need more of an anti-anxiety or antidepressant in there, right? And I do see a
Absolutely.
lot of that I do cover for a couple of family doctors. So I see people that, for one time that I've never met them before, they come in and we're talking about things and I look and you see these incremental increases of anxiety medications and they're not getting better. They're not feeling better. Plus they have a whole plethora of other symptoms that just scream perimenopause or menopause. And unfortunately, it's been missed. And again, I can't blame my colleagues because it's something that they're not trained in per se. But
Yeah.
when you see it, it's actually really liberating and exciting as a clinician. And then when you explain it to the patient, they're like, oh, maybe is that why this is happening and that's happening? And of course, inevitably libido's in there. But then what we've done is by increasing these medications, one of the biggest side effect of these medications, right, is
Yeah.
low libido
Low
for men,
libido.
erectile dysfunction, right? These are common, and which is unfortunate because in people who need to be taking them because there's truly an imbalance, they may stop taking it because of the sexual side effects and
Oh,
they want
yeah.
to preserve their libido. So it's really a double-edged sword,
Yeah.
but it's such an interesting concept when it comes to libido, right? Like there's such a psychological component. It's not just strictly
Oh,
one hormone or two hormones or three hormones that are out of whack. It's really just there is a huge psychological component
yeah.
there.
And now along those lines, like a lot of clinicians who don't have any background in, I mean, I think the menopause training and specialization does give us some, it gives us a window into sex. It's not the whole picture. But what
For
I
sure.
do find is a lot of times when women end up seeing me for either or both, they have actually seen sometimes a rheumatologist, sometimes they've seen an orthopedic, sometimes they've seen a mental health provider or been urged to do that. They've usually been like referred out or seen other specialists when nobody actually goes, hey, all of these things fall on a list of common symptoms of like a menopausal transition, especially in perimenopause. Like it rings a bell for people when someone hasn't had a period in 12 months.
Totally. Yeah.
But the rest of it, it's just so funny to me how, like, I would say the overwhelming majority of people that come to me, and I don't know about you, they've seen at least one other specialist that their primary doctor, their family doctor, their internist has sent them to because nobody put the light bulb on and said, oh my God, this is you're 48 and you have skipped a couple periods. Maybe all of this is partially triggered by your hormones right now.
Oh, for sure. And that's one of the biggest issues, I think, with women understanding where they're at with their bodies is that there are the known symptoms of perimenopause and menopause, and then there are about a million unknown, or not unknown, but less known, I should say,
Yeah, absolutely.
symptoms, right? So,
Yep.
and there's a reason why I called the podcast the Hot Flash Diaries because people will read that and say, "Oh, I know what that means. I know what that
Yes.
is. I understand who the target audience is." If I would have called it like Frozen Shoulder Diaries, they would have thought it was an orthopedic
Absolutely,
podcast,
right?
right?
Or an itchy
But yet,
ear diary or a
yeah,
yeah.
exactly.
They'd ban you
So
if it was dry vagina. The
they
dry
would
vagina.
totally.
Yeah.
I should have actually called it something like, because all these women that I see now with these rashes and these histamine intolerances and all of this, I'm sort of like the rash diaries. That sounds really gross in dermatology. But anyway,
Ugh. Yeah, it's
something like that because it makes you itchy. But all that said, like there are so many symptoms that people don't know are associated. And it's so funny that you say itchy ears because I've actually seen about 4 or 5 of them in practice recently that I'm like, that's what it is. And it's amazing what a little estrogen cream will do for you, and not just in your vagina or externally.
right.
But that all said, you sort of alluded to another large component of the libido phenomenon, if you will, as being that of your relationship dynamics, right? With your partner, your household, like your children, if you're a single parent. But that is so huge. I hear women that come in and they're like, we don't really get along that great, or there's been some sort of major event like the death of somebody in the family,
Yes.
or a recent diagnosis of some sort that's life-changing for a family. And I think that people forget just how traumatic a lot of that can be for us, especially as women being very cerebral
Yeah.
human beings, and how that absolutely is directly impacting their desire.
Yeah. I mean, that again, I tell people like, there's always the context in which you live, and we all are aging, even like men who don't go through menopause. Things are changing. I wish we could live in the bubble of like our carefree, most likely child free 20 something self, or, when we had so little things that and the adulting you could kind of handle. It's so different when and we can't stop it, right? Like life is going to happen to us. The dog is going to get sick. Our parents might die. Your child might have a diagnosis, your partner might have a diagnosis, you might have a diagnosis of something like cancer or diabetes that affects everything. And we can't live in a bubble where none of that is happening to us or the people around us as much as we want to, right? So that has to play into whether or not you're in the mood or whether or not you have the mental, emotional bandwidth to actually engage. And if you don't, sex when you're unengaged and you're just doing it to appease a partner, the number of women who do that but can't put themselves into the moment, it makes them dislike it even more, because if you can't
Uh-huh.
focus on all the good stuff that happens when someone is trying to please you, and when you're trying to have that kind of pleasureful connection with someone else or multiple people, if that's how you roll, if your brain is elsewhere, it is not going to be good, right? If you are sad or grieving, it's not necessarily going to be good. And there are definitely times when, it needs to be a back burner thing, but we don't want the entirety of life as an adult or a mid-aged adult to also make that a backstage kind of piece.
No, for sure. But
It
I think it
deserves.
helps to bring awareness, right? Too, so that
Absolutely.
women can it's really validating, right? I am
Yeah.
not feeling like being intimate or have that sexual desire today, this week, this month because our pet died,
Yeah.
and it's really sad. And maybe you can identify that that's why that you feel that bit of, sadness, anxiety, perhaps depression around that. It's situational. But there's a reason that you're feeling that way, and it's okay,
Yeah.
You'll come out of that eventually, but it's also honoring where you're at in the moment and knowing that you are not a robot and you can simply just flip a switch to say, I want to have sex now, and then, be lubricated and ready to rock. Like, that's not
Right.
how it works. Yeah.
Yeah. No, I know. I mean, and a lot of people do. I think we're going to touch on this at some point, but there's just so much inaccurate education about sex in the world to begin with. And there's just so many, narratives that roll from one perspective that just make sex out to be something so narrow that if we take the time to understand, all that it can be and all of its dimensions, that also helps, right? It doesn't need to be simultaneous orgasms from penetration. There are so many other ways in which you can engage sexually with someone that is still sex that counts, right? But we
100%.
discount it
Yes.
a lot because we don't know or don't teach that.
Or maybe because it was different than it was 5, 10 years ago, right?
Exactly.
It's just, it looks different now, but it really is under the same umbrella. But for sure, there are so many misconceptions around what sex is and what healthy sex is. I had somebody ask me the other day, how many times a week should they be having sex? And I said, well, that's not for me to answer. That's really
Right.
for you to determine how often do you have the desire and want. And it's a relationship with yourself and with your partner. That was one thing I
Right.
really appreciated from my conversation with Dr. Nan Wise, who's your
Yeah.
dear friend, really talking about that exploration of yourself too. Like, how on earth could you possibly have good quality intimacy if you don't even know how to pleasure yourself, right? And to
Yeah.
really know where your pleasure centers are for you, because they're different for everybody.
They are.
And maybe it's seeing your partner cleaning the house that does it for you versus, wearing a sexy outfit or what have you, right? Like, there's a million and one things and nobody knows, there's one meme that's floating around Instagram right now that just makes me laugh. And it's the husband that's disciplining the children. And you can clearly see that the spouse is turned on by the fact that the husband is disciplining the children, right? Just to say, like, you need to clean up your toys. And then she's like, all hot and bothered. I mean, whatever turns your crank, like, that's like
Yeah.
very individualized and that's all good. But you need to know for you, what
Mhm.
that's not for somebody else to answer
Yeah.
or for your partner to say, oh, we need to have sex 4 times a week. And if we're not, then that means our relationship is not healthy.
Yeah, that's definitely a dynamic thing too. I think, when I was 20, there were things that would work that absolutely do not work now. But, that question about normal, I get it all the time. I actually got it more than once from the AARP because I do a lot of work with them talking about like sex over age 50, and people always want to know what's normal, and they don't like the answer, but I have to reiterate all the time, like, normal is what's normal for you. And that
Totally.
normal may evolve as well. It may evolve into more sex. It may evolve into less sex, but that's going to change with you as, like from day to day, week to week, year to year. All of those things, can evolve as well.
Absolutely. Well, that's exactly it. And I think just reassuring people. I know it's a sort of open-ended response and some people who are structured they just want a number. But again, it's impossible. It's impossible to say that. So I think again, just trying to hear where the person's coming from. But I always like those questions because I feel like it's a good intro into, how the person is feeling and trying to identify if there's more to it.
Absolutely.
So, with that, I've chatted in a few of my other episodes about vaginal dryness and physical changes that come with, of course, hormonal changes. Pain and discomfort while having intimacy is a pretty fast way to tell your brain to, rewire your brain into thinking that sex is not comfortable, right?
Yeah.
And so, therefore, you do not want to have sex and everything gets shut down. Can you chat a little bit more about that? Because again, my mission is really to educate women around the safety of vaginal products, whether it's a lubricant, a moisturizer, or a hormonal product, so that they can have a more enjoyable, intimate life.
Yeah. Well, 100%. Some of the women, and I don't know if I had to guess, I might say it's like 20%, 20 to 30% will come in under the guise of like, I've lost interest in sex. But if you ask the right questions, it is not that they have lost interest, it's that it hurts and they don't want to do it. I mean, I've had women describe it as like a wire bottle brush, 1,000 shards of glass, like they got sand in there from being at the beach, like horrible things, right? And so I always tell them, and I think it's worth repeating what you just said, but like you can't want to want something that hurts you. Yes, there's sadism and masochism, and that's a whole nother picture. And that pain brings them pleasure. And it is not every time there's penetration, I have this unbearable, new, unexpected discomfort. That is a completely different box of fun. But what we're talking about here is like anatomic changes, hormonal changes that come with a menopausal transition, some earlier with women than others. Usually by 3 years post-menopause, I think it's like 75% of women have dryness and irritation that makes it very difficult to have sex. So I think the one thing I do jump up and down about, even if I don't bring people back right away, is that like you need to do something. One, lube, always lube. Lube is not a failure just because you're not like dripping wet like the romance novels say you should be. It does not mean that you are not in. Your brain is your biggest sex organ. And I'm going to say that again at some point, but it is. It's your biggest sex organ. Your body
Absolutely.
doesn't always respond. And in menopause, it doesn't have the same capacity to respond. So yes, use lube when you're sexually active. If you don't want to use hormones, which there's really almost no reason not to use a topical estrogen product really at all. But if you don't want to use any kind of topical hormones, the least you can do is use a vaginal moisturizer that will stay in the vagina. So you want to make sure that it's like, the osmolality is appropriate for it not getting like sucked up and absorbed, but that it will like coat and protect to the surface layer. So at the very least, when the lack of estrogen prevents the elasticity and the moisture, you will have like a slippy, protective, healthy base so that you don't end up with as much people sometimes have like little spotty bleeding every time they attempt to have sex with that.
Sure. They have tears and
Tears,
all
yeah,
kinds
micro
of
tears in the
fissures and
vagina
things that
all
happen.
over. Yeah, and that's not pleasant. And those get harder to heal also without the estrogen. So I have some patients that have some chronic fissures that are really we're struggling to fix. But the last piece of this is that like literally there's almost virtually no one who would not benefit from using a topical estrogen product. If we don't replete some of the estrogen loss at the vestibule, so 360 degrees around the vaginal opening, the urethra, the urethra and the bladder. Like there's just a huge pile of side effects that nobody needs or wants. Nobody wants a higher risk of getting a UTI. Nobody wants like more of an overactive bladder than is, I mean, it's never necessary, but it's definitely going to happen with the estrogen loss. And then nobody wants that soreness, lack of elasticity. Nobody wants any of that. And nobody should have to deal with that. Like it is.
Agreed. Yeah.
So, I mean, I think I give it away. I know you're in Canada, it's healthcare is a little different. We have some issues with insurance covering it, which I think is crazy. So I
No, it's
do.
crazy.
Yeah. And so, and it's been, generic for eons. Like I went to go pick mine up at a grocery store and they told me it was at our pharmacy at a grocery store, told me it was gonna be $250. I was like, you gotta be kidding me. So
For
when
how many weeks or months
for
supply?
like
That's
one
crazy.
42, whatever it is, 42.5 gram tube, which is basically
Oh,
2 to 3 months if you're using it
right.
internally only. I tell people to use it externally all the time too, because it helps so
Yes,
much more. But I
for
have
sure.
a handout that I'll give people about where to use it and also about where you can get it cheaper because I am so sorry.
No, don't worry. It's
There
okay.
are pharmacies, usually mail order pharmacies, where they will give it to you at generic cost. So my
Yes.
cost personally went from $250 all the way down to $17, like for,
My
2 to 3 months. It's ridiculous.
That's robbery. That's
It is.
terrible.
So that for a long time, and even still recently, has been something that's been prohibitive here, at least in the States. But I try to help people in all ways get around it. And I'm literally gotten to the point where I'm flat out rejecting there. It's going to give me breast cancer. I'm like, nope, how many studies do you want me to give you? It's not going to
Right.
do that. It's not even going to increase your systemic estrogen levels. Like, it's just going
No.
to make you feel better. It's going to make sex better. It's going to give you less infections. So I preach it all the time. It is one of the things that I'm giving to people left and right. And it's safe. I really hope, at least in the US,
So
they take
safe.
that warning off because I still today on my desk, I had a paper thing that was telling me that I couldn't give someone an estradiol patch and their vaginal estrogen cream. And I was like, I don't have the time to call and educate every person who works at an insurance company and a pharmacy. And
So
like,
frustrating.
it's
Yes.
frustrating because I'm going to educate my
Yes.
patients. I am not going
Yes.
to give them the time of day. So,
It is so frustrating. I have had quite a few pharmacists that I've had to chat with for the very same reason, denying them their progesterone or their prometrium
yeah,
because, they're not exhibiting hot flashes. Well, newsflash, it's not just for, I mean, first of all, it helps minimally for hot flashes. It's for about 400 other reasons that I'm prescribing it, and you're
yeah,
not the prescriber.
yes.
But when it comes to vaginal products, it's actually interesting in terms of cost because I went down the rabbit hole of looking at the cost for patients who don't have third-party insurance.
Mm-hmm.
And the brand name Imvexi was actually cheaper than good old Vagifem from, that's been around for a
Forever.
bazillion years. And I tend to prescribe the tablet as opposed to the cream just because I find most people don't like the messiness of the cream, but I will prescribe the cream for the external if they
Yep.
need that too. Yeah.
Yeah.
But we also have, I don't know if you have this in the US, I think you do, Interosa, which
Yep.
is the DHEA,
Yep.
which is just fabulous
Yep.
too. And it's actually less expensive than even the least expensive estrogen. So when people are open to a product that they'll use nightly, which most are because once you get into a routine and then you feel how great your vagina feels, it's like,
Right.
why would you say no to that? But fantastic product. And then it also is replacing some of the testosterone at the level of the vulvar vestibule, as you mentioned, and all of
Right,
that. So
because of its metabolites.
it's really
Yeah.
fantastic.
Yeah, no,
Yeah.
it is. I do tend to make sure that everybody has vaginal estrogen, and I like it, but it is messy, and I will do absolutely the same thing. If it's easier to use some kind of like the Vagifem or Interosa or anything, fine. But I still think we need to treat the vestibule, especially for
Yes.
sexually active women, because like that 6 o'clock spot, which is if you're looking at it, right, the bottommost part of the vagina, the vaginal opening that's closest to your bottom. I say this a lot to people, but I'm like, it doesn't matter if you're in missionary, reverse cowgirl, or doggy style, that area is going to get the most friction and pressure.
Yes.
And you need to treat it nicely and allow it to be like stretchy and tolerant. Otherwise, it's not going to be fun.
Well, and it's no coincidence that's one of the most common areas to see fissures too as we get older as well. Um, we have in our clinic, we have the B Pulse chair, which is the Canadian version of the Emsella chair. I don't know if you're familiar with
Yeah,
that, but it's
I
that
am.
the EMS, the magnetic energy, basically that does your Kegels for you.
Yeah.
And above and beyond the pelvic floor strengthening component, one of the things that I absolutely love about it is that it's also stimulating blood flow, right? Because
Hmm.
blood flow to the pelvic floor and to the vaginal area really starts to become, a little more challenged as time goes on, just like it does to our fingertips and our toes and our nose and our ears and all the things in between. And for men, their penis, right?
Hmm.
And so without good blood flow, then you start to lose some sensation and also your healing time is impaired. So I really like to sort of mix things up and use that for the purpose of blood flow as well. Although I'm careful in the context of a tight pelvic floor because we don't want to make things tighter.
Worse. Yeah.
But that's where we get our friend Kristen in to see our patients and say, yep, yes, no, so we can safely treat them. But it's again, multifactorial and a huge part of libido, a huge part. I mean, if you're having pain with intimacy, you are going to tell your brain absolutely not. And your brain is your biggest sex organ, period.
That's right.
So, yeah. So now tell me how you help women sort of determine which part of the million and one things that could be affecting their libido that it could be. How do you help them pinpoint? Perhaps it's a combination of 3, 4 different things. Like, how do you help them come up with, figuring out what is most significant in their particular individual situation?
Yeah, I mean, definitely I fought to have more time to have these discussions. And then I say this too, it's like lube always lube and your brain is your biggest sex organ. I feel like my superpower is talking about sex. Even with partners in the room, even with like angry or irritable partners in the room, like with postpartum patients, like I can tell them like if you're not ready, you're not ready. Sorry, buddy, but like she needs more time. I feel like I'll let them start telling me what's going on and I'll ask follow-up questions. And we'll keep talking. And I think that I'm down to earth enough, again, another superpower, that people feel comfortable. And I do think that gynecologists a lot of the time miss the mark. Yes, we need to be professional, but if you are stuffy and you don't listen and you're not understanding, or you're not hearing what they're telling you, then you are not really going to make them comfortable enough to talk about sex. And most providers don't bring it up to begin with. So if they're opening up to you, like I ask follow-up questions and we go down the talking about things. And I know some of the classic things we've already talked about that can affect how things are going. But I mean, I get into partner dynamics. Like, is your partner helping you with the household? Do you live alone? Do you have, did college kid move back in? Do you have any time alone? Wait a minute. Your schedules are that you only have Saturday nights in the house together and otherwise you travel on different schedules. Like you have to peel the onion. So I will ask relationship questions. I will ask about, masturbation and those kinds of things. I will ask about if things have been this way for a long time. I will ask about previous relationships. Usually it comes out. And in the small cases where it hasn't, I do get people have like blurted it out to me when I've got like 5 minutes left. They'll be like, oh, by the way, we lost a 16-year-old daughter 2 years ago. And I'm like, and she goes, I didn't want you to think that was the only reason. I'm like, clearly it's never the only reason. But like, if you don't think that's still a reason, and she goes, oh no, I think it is. And I said, well, then I'm glad that you brought it up so we can talk about it. But, validating all this stuff, but it's an onion. You got to peel layers. And some things people are hesitant to talk about, but you have to look at the whole picture, right? The relationship and how that works, what's happened in the past with that partner or with other partners. You have to look at what's going on medically. Is it perimenopause? Does someone have cancer diagnosis? You've got to peel all these layers. Who else is in the household? Do you have any time to yourself? Like, what is your stress level? All of these things. Like, how did you learn about sex? How was it growing up? Are you terrified to have sex because it was always a sin and naughty and they were going to kick you out of the house if you got pregnant? Like,
Exactly.
there's
Yeah.
so many pieces that you just have to, I try to make it as natural of a conversation as possible, but I just peel the onion until we find things. And then I ask the patient, how much do you think this is affecting what's going on? And usually they'll say a decent amount, right? Like the other day I found a woman who had been with someone for like 6 years and like faked an orgasm for 6 years. And I was like,
Goodness.
okay. So, we can do one of two things if you want to fix this or work on this, right? So we kind of like started talking about it. But yeah, whole relationship partners supposedly never knew that she was just faking it. And she's like, how do I undo that? Like, well,
Right.
so we go through so it's complicated and it does take a little bit of time because it's so multifactorial, but I think just by listening and asking questions and having an honest conversation, which I wish there was more time in the regular office to do, but I also wish people who are providers like us who know this stuff, but there's so many who don't. And they will tell people like, "Oh, go have a glass of wine or use more lube or you're too young for those symptoms." Like those are some of my biggest pet peeves from like the general population of providers because none of those things are ever the answer. Like, honestly, like
No,
not even under any circumstance. I mean, unless
they're
you're,
not even a Band-Aid.
yeah, not even. It doesn't help
No.
anything. And what it shows to me is their discomfort with the topic and probably their lack of knowledge on the topic, almost definitely. But it's hard for patients. It's hard. So we've got to do better, you know?
And it also puts blame in the
Yes.
towards the woman. Well, it's
Yes.
you're not relaxed enough. Go and have a glass of wine. Like on in what planet does that make sense? No. And a glass of wine is actually going to dry your vagina more, for
Yeah,
the
and what
record.
perimenopausal woman doesn't complain that, like, they can't drink wine like they used to? All of a sudden, they're like, "I used to have a glass of
Exactly.
wine here and there, and now I can't. I wake up with a headache." And I'm like, "Yeah, we
You
get it at
just don't
all
metabolize it the
angles."
same.
We
Yeah. Well,
don't.
it's true. And then you get somebody who's uninformed and uneducated and just adds complexity to an already complex matter. But it's so important, like you said, to just I love your analogy of the onion, like peel back the onion, right? It's so true. There's a million and one different things that are involved in determining what is affecting your libido. And truly, my default is we will peel back the onion for sure, but I am not a psychotherapist.
Yeah,
And
me
I
too.
encourage my patients big time. Listen, you need to go and see a therapist if you're willing, by yourself at least, if
Mhm.
not with your partner. And I think that that is so important so that you can have some, open, honest dialogue and then determine from there, how do you get past this and move forward so that you have the type of sex life and intimacy that you both desire? Because it takes two. Also, I love how you asked about you said you ask about masturbation and so forth. It's so important. You need to know your own
You need to know
body,
your
right?
body.
Again.
You do. You
And if
need
you
to know
don't,
what
then
works for you. And,
and
if
that's
you're
the
a good
thing.
partner, you should also, like, want to know what works for your partner and ask them. I mean, it goes
Exactly.
both ways.
Exactly. And to that point, I think that there is such a huge gap, not only with women, but with men
Ugh,
understanding
they
the
don't
hormonal changes.
understand it at all.
And so think I think, interesting because again, in family medicine, having both the husband and the wife as patients and having seen them for different things, when a woman comes in and expresses what's happening, and then knowing the partner, albeit on a superficial level because they're in, for a handful of times, you think it's just that he doesn't know.
Yeah.
And he just needs to know. So let's educate him on this. And that
Mhm.
in and of itself is super empowering to say, oh, wait a minute. And the number of women, even just with the addition of some vaginal estrogen, how it's life changing for them. Not only are they not getting UTIs anymore, they're actually lubricating somewhat and then not feeling like it's a failure having to use lubrication. It's just amazing how it can be so effective for people. But yeah, it's a huge topic.
It is. Yep.
Yeah.
Lots of education, even for people who might not be in the room.
Yes, exactly. Exactly. So, with that, I'm going to conclude this episode and we're going to move over to our episode 3 of the Hot Flash Diaries momentarily, where we're going to talk about all things of how to solutions and action plan towards how can we sort of improve all of these different aspects of our libido. Of course, it's going to be very, very individualized, but we're going to go through some of the things that you can do to improve things if you want to improve things, that is.
Right.
So we'll see you over in episode 3. Thanks so much for listening and we appreciate your time. Have a good day.